If you are going to be doing any health promotion work, you need to have some kind of underpinning model or theory that you're working that project around. So this screencast is just giving you a very, very brief overview of what models are, what theories are, and how you might consider using them. So is it a model or is it a theory? What's the difference? So models are ways of just looking at things differently. You all know that we have different ways that really work for us on helping us to understand things. So visual things can be a lot easier for a lot of people to understand and get hold of. So visual representations, flow charts or different diagrams can help us to think through what we're looking at and what we are going to do in practice. And here I've just given you two or three examples of different models that are very well known in relation to health promotion. But a theory is a different thing. A theory is actually about what we know. So it's about our knowledge that could be applicable in a variety of circumstances. And theories should be something that's help us understand what process is happening when we're undertaking health promotion work. And it should be subject to research. So we're looking at something that someone's actually done some primary research to try and provide evidence for the theory that they have and they want us to understand. So the whole idea is helping us to, analyze, explain what is happening. Or if we're using a theory to plan something, which again, you're going to need to do with your coursework. If we're using a theory, then that theory might help us explain what we expect to happen when we do a particular activity. So it's very important that it underpins any planning, implementation or evaluation of what we are doing. So theories are really important. Having a clear model that we're focusing on, again, is really important. So let's have a look at just a couple of examples. There are loads. So Tannehill is one of the most common models of health promotion. And it kind of sits with an understanding of health promotion that's been around a long, long time, and which covers preventing things going wrong with our health, protecting health, and educating about health. So a few years ago, those three aspects would be seen as the key things that you would be doing, kind of tasks. You'd be trying to protect health, educate about health, prevent poor health, all of those things. But this model shows you that they actually overlap and that we could be doing a variety of things. So if you look down the numbers on the left-hand side, prevention, that might be immunization, screening. So we're trying to prevent something happening, but particularly things like immunizations are really important. We're trying to stop somebody get measles, which is a massive issue in our community at the moment. Measles is going up because people haven't been having the immunization. So prevention is all around that. Preventive health education, that's the kind of stuff that we might be doing to try and prevent ill health. And provide people with information to try and encourage them to use preventive services. So like smoking cessation, for example, but you might then give them nicotine replacement therapy at the same time. Preventive health protection, that's something like fluoridation of water, which still can be quite a contentious issue. But if we have fluoride in the water, we know that dental caries are much less likely to happen. So fluoride's incredibly important. Putting it in the water makes it completely accessible. People don't choose about it. They just have that health protection mechanism put in place for them. to prevent dental caries. Encouragement to use seatbelts is an example for health education. So for most of you, seatbelts will be something completely normal. We all wear seatbelts, that's what you do. But you can imagine, before that was a legal framework, we had to educate people. So when the law came in, people had to be educated. So there's a big media campaign to educate people to use seatbelts to protect them. Health education, that might be a lot of things that we do actually, teaching people to follow a specific diet, supporting cooking skills. There's lots of aspects of that we might do. Positive health protection, that might be things that come into place, such as workplace health education or healthy eating policies. So we're trying to protect people by making sure that in the workplace there are healthy options, similarly with school meals guidance. And so then you've got to educate people about those things to make sure that they recognise them, they can make those informed choices, that the people know how to follow the guidance. So we've got to educate the providers to make sure they're doing that. So all of these things have this overlap, which together covers most aspects of what health promotion would be. A much simpler model is the Tones Empowerment Model. This has been around over 20 years as well. The guiding principle is we enable people to take control of their health. So it's all, the underpinning part of this is all about empowering people. So what we're trying to do, though, is change public policy to make it easier for people, and we educate people, and the whole idea, you come together, you promote health from those two directions. We make people more aware, we give them information that they can act on because the public policy has made it easier to improve health. So much simpler. Whether it's useful or not, I leave that up to you. You think which you think is the most useful. Now, theories, there are absolutely buckets of them. There are books of theories, health promotion theories. Some of them that you may well have heard, the health belief model, theory of reasoned action, or theory of planned behavior, social cognitive behavior, stages of change, very well recognized model, sometimes called the trans-theoretical model. And that actually could be really useful for something like smoking cessation, much more complicated with dietetics, because dietetics isn't about one change, and it's about a lot of different things going on. So we don't normally have one dietary change. It's not normally like stop eating apples. It's much more complicated than that. So the evidence base around dietetics for these models is very, very limited. You occasionally see things, but it's really quite limited. But I just want to encourage you to go back to thinking about what we learned in professional practice, and think of the COM-B model and the behaviour change wheel that still is part of what the NICE guidance on behaviour change says. It's not changed. That framework, they don't call it a model, they call it a framework, intuitively makes a lot of sense. And that's what the guidance is. If you look at that NICE guidance, it says there's no particular model that stands out as working better than any others. So when you're thinking of health promotion, it may be that the thing you are particularly wanting to do fits nicely with one particular model or theory. But what also confuses this is that some people call their theories models, and they have diagrams to demonstrate them. So the health belief model would be one of those. So if you look that up in a health promotion coursework book, you will find there's a picture to try and help you understand it. But it has also been researched. So it's not just an idea. it's got a research base behind it. So that's probably the key thing. So it's a very confusing world, models and theories, but hopefully you've got some understanding of the difference between the two and the research and actually having some theoretical underpinning rather than I think this idea works is really important.